Hi, everyone, and welcome to another episode of Sarcoma Sisters. We're really excited because we have someone who is amazing, but also a good friend of ours, Dr. Weiss. And just let me tell you a little bit about him, and I'll give more in the real intro, Aaron. But Dr. Weiss is a division director of Pediatric Hematology and Oncology, an associate professor at Tufts University School of Medicine, and the Samuel Cohen Medical Director Endowed Chair at Maine Children's Cancer Program. And that's where he works as an attending physician and leads the team. He's also an integral part of Children's Oncology group and their sarcoma teams. He's the vice chair of the soft tissue sarcoma committee, and he's also the associate vice chair of the clinical trials AYA oncology discipline committee. And then the main reason we're talking today is also his expertise in Desmoid tumor, and he's the chair of the Desmoid Tumor Research Foundation. So thank you, Dr. Weiss, for being with us here today. And we're going to start off with just having you tell us a little bit of about yourself and how you got into pediatric oncology and sarcomas and desmoid. Go for it. Thank you for being here.
Well, thanks for having me. This is very exciting. So I'm currently living in Portland, Maine, but I'm not from there originally. I grew up in the Philadelphia area and did my earlier training during that time, and then ended up doing my fellowship at St. Jude. And then from there went and had my first job in New Jersey, and then in 2012 came up here. But early on, probably during fellowship, I got interested in sarcoma, mainly through one of my biggest mentors, Sherry Spunt, who was an attending at the time there, and so was someone I shared my clinic with, and so got involved. And she at that time was running the Children's Oncology group study for non-rhabdo soft tissue sarcomas, and so I got involved with that and was fortunate enough to kind of do the successor clinical trial through her mentorship, and she was the vice chair for that. And so that kind of began my career into the world of sarcoma, and since then have kind of got involved in a lot of other initiatives, including desmoid tumors. So that's something that a lot of people don't know a lot about, and for reasons of rarity and other reasons. And so I got involved with that when I was working early with Steve Skapik on a small pilot study, and we applied for funding through the Desmoid Tumor Research Foundation. They gave us a grant to be able to run a small study, and through that organization, I got more and more involved and interested, and now I'm the director for the medical advisory board there, and do a lot of work with that organization.
Thanks, that's great. And yes, as you mentioned, you didn't mention this, but you are an expert in all these soft tissue sarcomas, which are also rare. And I think that's what makes it difficult and unique. And for patients and families who have that rare type of sarcoma, they're an expert in that too, but everyone else, it's still something so rare and new. So I know not everybody knows what a desmoid tumor is or how it acts, and it is a very unique type of soft tissue sarcoma, kind of in the way it grows and doesn't tend to spread. So maybe you could give us a little bit more information about desmoid and the type of tumor it is and how they work.
Yeah. Is it a cancer?
Yeah, so if you talk, it's a great question. I can tell you that one of the issues and one of the reasons why we don't know a lot about it and why funding for this type of disease and studies have been so limited is because of that kind of definition of cancer versus not cancer. I can tell you people who have it and people who treat it think of it as a cancer, and that's how I view it. Because it is a growing a growing tumor. I think that the problem is, since it doesn't metastasize or spread to other parts of the body like other cancers do, it oftentimes doesn't get that same designation. There's an organization called the WHO classification group. Then there's a number of pathologists and providers who get together, and every few years they revise this. This is basically a classification of all these different types of sarcomas, and within that, desmoid tumors is considered an intermediate type of non-metastasizing behavior type tumor. And so it has kind of its own designation, but it is considered one of these non-rhabdo soft tissue sarcomas, which in itself is a confusing term. There's over 50 of these different types of histologies, and desmoid tumor is one of them. And rhabdomyosarcoma being the most common, soft tissue sarcoma, so it has its own category, but everything else is kind of in this non-rhabdo category. And within that, desmoid is even in its own category because the treatment is so different and the characteristics of the disease are so different. So we think and manage it in a much different way. And so it is rare. I mean, all these sarcomas, as you point out, are rare. Desmoid tumors even more rare. They're so rare that we don't even have a true idea, at least in children, of what the true incidence of desmoid tumors is.
One thing I wanted to back up to, and I guess I'm a bit embarrassed that I don't know this, but there is a similar story in cancer and funding or lack of funding based on the classification. But you had mentioned that part of the problem why we don't know as much as we would like to know about desmoid is because it's not technically classified as a malignancy, even though it's this little, carved out niche in the WHO classification. But another story like that was Langerhans cell histiocytosis, where it wasn't a clonal malignancy, and then it flipped in, I want to say 2019 maybe, or 16, I can't remember.
Recently.
And then that sort of opens up funding from other agencies. And I wonder if you could talk a little bit about that and some of the struggles that we've had in desmoid and why that classification is so important and is more than just a label.
Yeah, it's a great point. And actually, one of the big initiatives of the Desmoid Tumor Research Foundation, which we can talk more about, is actually to change the designation. And so, there's ICD-10 codes for all these different malignancies. Desmoid doesn't have its own code. And actually, there is a big effort afoot to change that. And I think just for the reasons that you state, I mean, we've had a few drugs of interest that have come through the pipeline recently. And when going to the FDA and trying to get approval and designation for desmoid tumors, one of the struggles that we always come up against is the fact that it doesn't have kind of its own CD10 code. It's not kind of in that malignant cancer category. And I think that does hurt tremendously for funding. I can tell you firsthand that when I was putting my pilot study together that we did, we actually initially went to a pharmaceutical company to try to get drug supplied, and they wouldn't supply the drug. And the main reason they gave is that it wasn't considered a cancer. So those are some of the struggles that you go up against. And so I think what the Langerhans cell histiocytosis Society has done, which is actually a really good model that you point out, is something that they're trying to do in the desmoid community as well for the same reasons.
And so I think it's important in terms of what you're eligible for based on that classification, but also we've talked quite a bit on here on clinical trials and the way that people accept risk in clinical trials from either a sponsorship point of view, from the people that are supplying drug or money, is, what is the risk to the patient versus the risk versus the benefit. And it could be conceived that it's not as dangerous of a disease or as a life-changing of a disease, but those of us who treat it and those people who have had desmoid, we absolutely know that it's true. So there is a very big disconnect there of the risk we're willing to accept in a clinical trial if it's not considered a malignancy. And so I think it causes a lot of problems.
No, you're so true. And that's actually one of the reasons why for clinical trials now, we're trying to actually move quality of life and some of those measures as primary aims and indications for drugs, because as we know, for patients that we treat who have this and families who go through it with their children, it's a life-altering, devastating disease. And although it can be fatal for sure, the majority of patients, it's more of a morbidity or complications of the tumor, the therapies that they go through. And unlike other cancers, this is lifelong for many people. Even if they have a surgery to remove it, there's a high likelihood it's going to come back. So it's really more of a chronic disease. So I think the measures and the endpoints that we use for studies really need to shift. It's just that we may believe that, but those have to be accepted endpoints by the FDA and other pharmaceutical companies that are designing drugs that they're willing to accept in order to move move some of these therapies forward. But the risk benefit, you're right, is it's a very different approach when you're having a conversation with the family about the risk and benefit. I do think those have to be factored in.
Yep.
Yeah, that's what I was thinking about actually when you start talking about it, about the quality of life, because the patients that I've treated, it was all everything that they struggled with. Exactly. It wasn't that the tumor was life-threatening. It was that they couldn't even do the things that they used to do, mainly because of the locations of the tumors. Either they were inhibited with playing sports, and because it did cause pain and other issues. And that's what I was going to have you go back to, talking about kind of what are these tumors, like where are they located, and why do they cause such a decrease in your quality of life depending on where they're at?
Yeah, it's a good question. I mean, they can generally appear anywhere. I mean, it's what we call a mesenchymal tumor. So those cells are kind of located anywhere, kind of throughout the musculoskeletal system. So they can appear anywhere, but in general, age does play some role. So those patients that are younger tend to get it more in the head and neck, area, compared to older individuals who might get it in the abdominal area. There's kind of a distinction between intra-abdominal and kind of abdominal wall desmoid tumors. Extremities obviously are another area where these can appear. They oftentimes can involve nerves, and so it can be painful. It can cause dysfunction or inability to have normal motor function in a lot of ways. Obviously, if it's within the abdomen, then these are patients that may have organ issues. They could be life-threatening bleeding or other concerns, and obviously it can affect fertility depending on where some of these things occur. So and obviously cosmetic disfiguring. I mean, if you can imagine a head and neck and face, we've seen some tremendous, cases of patients, young children who have these masses that are not easy to manage, that really can affect their quality of life on many different levels. So this can appear anywhere, and based on location, we do alter our management or thinking about the management based on where they may appear.
And I know I mentioned it kind of in the beginning with how the tumor is, but then these tumors don't spread, and I should say don't have a distant spread. So what we would call metastasis, they're usually localized and grow in that area, correct?
They do. I mean, most of these are kind of single masses that grow within that region. There are patients though who do have what we call multifocal desmoid tumor or multiple desmoid tumors. So that's not necessarily metastatic spread, but they can have multiple desmoid tumors that can appear. They generally tend to be kind of around the same area, within the abdomen or something, but that doesn't necessarily have to be the case. But the majority of patients present with a solitary mass somewhere that will tend to grow, but they do not metastasize in the sense of like spreading to the lungs or the bones or the brain, of things that we see with other types of cancers, and that's what makes this type of disease unique.
So this is going to be a hard question, I think. As simply as you can you talk about the natural history of these tumors and why there is data out there on a watch and wait approach, and how that may or may not be different based on age or location?
Yeah, it's a good question, because it is definitely the hot kind of discussion topic nowadays. I will say that the United States is way behind the curve with this type of feeling about desmoid tumors and our philosophy. The Europeans have been doing this type of what you mentioned as a watchful kind of wait approach for a much longer period of time. People basically, some really astute people had made observations that there are some patients with desmoid tumors where these desmoid tumors either are stable for a number of years without any type of treatment, or spontaneously regress or get smaller. Rarely do they completely go away, but will sometimes get smaller, and that's without treatment. So the challenge is identifying who those patients may be, which is what is an active area of research right now. But we do have really good data, and quite a bit of it over a period of time now, showing that if you observe patients up front with desmoid tumor, almost 20 to 25% of them will have stable to regressive disease. And so that has led to clinical trials incorporating that approach. And more recently, they did that in a European study in children. Historically, people who had desmoid tumors would have this surgically removed. And that was really the mantra in the United States for a very long time. And still to this day, there's a number of centers that might not see a lot of desmoid tumors. And a surgeon would see them first, then have surgery up front. And I'd say that over the past couple years, there has definitely been a shift where there is less of that. But those are generally at places where a little bit more academic, or places where they see a higher volume of desmoid tumor patients, and therefore they're a little bit more in tune with some of the more current literature and philosophy. But we don't really know yet, which is really the question you're getting at, is like who, it would be ideal if upfront you could identify who are the patients that are likely safe to observe, that will not progress, or will have long stable disease. And right now we're just not able to do that. There are some factors that we're learning about. We're learning about certain mutations that these desmoid tumors have. Majority of them had beta-catenin mutations. There are certain types of mutations within beta-catenin that are shown to be a little bit more aggressive than others. So that is one thing, but that's not been consistent across the board. Age seems to play a role, where the younger children sometimes tend to have a more aggressively growing tumor. The location tends to impact this a little bit. There are signals on the MRI or imaging that you can look at that can sometimes help predict whether there are changes happening within the tumor that could indicate whether it's more or less aggressive. So there are some of those things that are starting to be looked at, but at this point in time, none of it's ready for prime time. And we have instead come up with some general criteria that we feel like where you could potentially feel comfortable observing somebody if they don't have severe pain, or they're not the tumor is not next to a life-threatening or impending type of damage due to nearing a blood vessel or an organ of some sort. So we've kind of defined those characteristics, but beyond that, it's a little bit hard to predict.
Yeah, I think it's just such a source of confusion and frustration for the families, and even sometimes for the providers. I think watchful waiting, is where we start here, but then sometimes there's people that you think you can watch, and then sometimes it doesn't go the way that you want. And that always feels terrible when you get into a situation where it didn't go the way you wanted. So I can't imagine on the patient side, sort of having this kind of gray, murky data, and physicians doing the very best that they can with the data that we have, but it's not clear cut, and there's not a one right answer like there is for some of our other diseases that we treat, other sarcomas. So it can be extraordinarily challenging.
Oh, I totally agree. I mean, it's so easy. I mean, it's relative. It could be easy for us to say, hey, we should watch this thing, right? But if you're somebody who has this growing tumor or this tumor inside of you, it's a weird concept, right? It kind of goes counter to everything else that we do in oncology. And even though, it is watchful waiting, like that's the way we think about it. I think one of the nice things is we recently changed the terminology a little bit. And in some of our more recent consensus papers, we changed to the term active surveillance. And I actually like that terminology a little bit, because it makes it feel as if we are actively watching it, right? As opposed to not doing anything, which watchful waiting we know is not that, but it gives a connotation like we're just kind of, not going to do anything. But when you say active surveillance, I think it gives people at least a little bit better sense. And that's what I'll use with patients and families too, the word active, so that we are watching it, closely. And it's not like, hey, come back in a year and we'll check you. We're seeing these patients every 3 months, sometimes 6 months. And we let them know if they're having symptoms to come back and find us. The other thing I think that's encouraging is that we do know that if there are issues that do occur, that there are a number of different options that we have that we didn't used to have in the past. So it's not like a helpless situation where, if it does grow, we do feel bad, but at the same time, there are things that we could do to potentially help with that. And the actual recent study that they published from Europe showed just that patients who did progress, who they initially watched, had just the same outcomes as those that got treatment up front. So we know that you're not negatively impacting the outcome of patients by delaying that treatment, which I think is valuable for patients and families to hear.
Yeah, I really like that term, active surveillance, because I think the words do matter that we use, and that is what you're doing. You're still watching it, and then, as you know, I think the hard part is too that even if you're doing it every 3 to 6 months, because it seems like a long period of time when it's you who has a tumor, but we know that they're not likely to do any growth in between then, so that it's like you would be getting all these extra scans that don't really help. And then the other point you made about the outcome, I think, is really important too. That watchful waiting didn't harm anything. It still ended up the same, whether you started treatment right then or if you watched and then it grew a little bit more. So I think those are what's really important to the families, and then go ahead, Wendy. Did you have another? I didn't know if we should switch to treatments or if you had another question.
That's what I was going to ask next. Yeah.
Yes, go ahead.
So, what I was going to ask is, you had said that, the mantra for a long time had been surgery. So in a hypothetical situation that does not represent anybody that I've taken care of or anyone that Lisa's taking care of, let's say that you try watchful waiting, or I'm sorry, active surveillance. You cut that out. We try active surveillance, and you come to a point where you say, we want to treat this patient now. Is the first go-to surgery still, or is it something else? Do you like my leading questions?
Yeah, that's a great question. I
Yeah.
think most of us will try something else before doing surgery. I think it's not that patients can't have surgery, and it's not like surgery is a terrible thing. I think the concern is that we do know that one of the triggers for desmoid tumors is trauma. And surgical trauma kind of fits into that category. And there's a number of patients who had some type of procedure at some point, and then a desmoid tumor grew within that region. We don't quite understand exactly why and how it happened, but we do know that that is a trigger. We also know that patients who have surgery oftentimes will have the tumor recur, whether it was completely resected or not. And desmoid tumors are also, unlike other tumors, they're not really well encapsulated sometimes. They tend to branch out and they're very invasive. So the idea of going in and getting the whole thing with clean margins is not so easy in many situations. So surgery, like I said, so one location that we would probably think about surgery more readily is like the abdominal wall. That's a pretty well established, and if you talk to the surgeons, who do a lot of desmoid, they'll tell you that abdominal wall desmoids are probably one of the areas that you could probably upfront do surgery as the first option. But for most other locations, you probably think about medical therapy first. And then it gets complicated because unlike other cancers, where at least when we start, for almost every cancer that we see, we have a kind of upfront standard approach, whether it's a clinical trial or not. We all kind of have general agreement about what the standard approach would be for children, adolescents with cancers. That's not the case with desmoids.
And before you talk, because I do want to hear about the systemic therapy, can you talk about radiation? Is that an option for these tumors?
Yeah, so radiation does work, and there have been studies that have talked about it. I think most people are wary about radiation for the same reasons. This is, once again, it's a chronic disease, so it's not like the radiation is going to cure what is there. And these are generally, if you're talking about children, these are young developing children who have a whole life ahead of them. And so the risk of radiation down the road is not benign. Depending on the location of these things in the head and neck, you could talk about cosmetic deformities. If you're talking about the extremities, you're talking about leg length, or arm length discrepancies and effects of motor. There's second malignancies that can form within these. There's disagreement about what the dose even would be for radiation. So I think in certain high risk locations, radiation can be considered, but I think for most of us, it would be way down on the list in terms of, and wouldn't be considered kind of an upfront option. And as we get more into treatment, more local interventional radiology type procedures is a little different. And I think about that differently, and I think would be actually a very good approach for many patients, but more systemic, like the kind of the way we think about external beam radiation or even proton beam, I think is for most people who treat desmoid tumor probably wouldn't be a front or even top 2 or 3 line therapy.
Yeah. And can you talk about some of those more local treatments that are not radiation?
Yeah. So I mean, we've talked about, we will talk about systemic therapy, and now we have surgery and radiation, but I think what's really been coming through the forefront, and more people are doing more localized therapy type work. And so hold on one second. Oh, sorry, my phone. But there are radio frequency type ablation, there are heat ablation, cryotherapy, like a lot of local therapies that interventional radiologists who specialize in doing these type of procedures on a number of different patients for different disorders. There are people who are doing this in desmoid tumor patients. There's been more published about it. Unfortunately, there's only a few centers probably in the world that have a lot of experience doing interventional radiology procedures on desmoid tumor patients, but that doesn't mean that it can't be done or extrapolated in other centers. Most places have interventional radiologists, and I think if they have good experience with it, the type of techniques and the approaches wouldn't be significantly different. But it is a situation where you'd have to think about, based on the size, doing it in multiple different, sessions, or knowing that it can recur, going back. But in the appropriate location, that would be a very nice way with minimal side effects for patients to have an improvement in their symptoms and potentially some regression or stabilization of their disease. That could be either an alone therapy or an adjunct, or in conjunction with other types of therapy.
Along that local line, I mean, I think like radiofrequency ablation, cryoablation, those are sort of things that we use for other things. And I'm again sort of embarrassed I haven't looked at the updated data on this in a while. Is there new data on the high frequency ultrasound? Or
there is actually some data, yeah, and it's not super new. I mean, but the last several years there has been some publications about using high frequency ultrasound, or HIFU we call it in short, for treating desmoid tumors. So there actually is some published literature about that, and I think that would be another option in centers that have experience using the technique. That's another safe, without really any of the radiation type effects, and I think could be very appealing for this type of disease.
do you do HIFU up in Maine?
No, they do not do HIFU up in Maine. We do have interventional radiology, but not certainly the expertise for desmoids. But I feel like if we had a patient that would benefit from it, the people here are skilled enough that they would be willing and comfortable doing it. But I think if you happen to be in an area where there is a large center, like there are a couple places in the country where there are people doing this, have more experience with it, I think sending somebody to a center like that, is not a bad idea, where they have just a little bit more volume and comfortability and have a little bit more knowledge about the subject.
Yeah, I selfishly asked about HIFU because I haven't actually had a patient personally use it, and where I was before, we didn't have it. I actually don't know if we have it here because I haven't needed to know if we have it here. I should probably look into that. But yeah, I was just curious about the update, because I have had a couple of people ask me about it, but we've been able to get things under control without having to send them out to the West Coast.
Yeah, I don't know how many people are doing it though. I think that's the issue.
Yeah.
But if there is a place that does it, I suspect that they probably treated patients with desmoid tumor.
Yeah.
And Erin, can you speak to how it works? How does the HIFU and the cryo, I mean, all kind of in the same sense, but what do they do to the tumor, or that we're hoping will come?
Yeah, I think right. I mean, honestly, truth be told, I don't know specifically how it works in the sense, other than like extreme heat and and cold and some of the other types of damage that are done to the cells themselves to kind of prevent the further growth. So I don't know exactly mechanistically.
Oh, that's okay. That's enough detail.
Yeah, how it works, but I know that but they all kind of have a similar approach in the sense that they're individually kind of targeting the tumor itself versus the systemic therapies that have effects beyond just what happens within the tumor bed. itself. And, desmoid tumors, I think the other thing about desmoid tumors that's so interesting is, you have the tumor and there's the cells that are growing, but it's also there's a strong sense that there's the microenvironment or the environment that the tumor is growing in and the milieu kind of that impacts the growth. So I think the local therapies also have the additional benefit of getting to that little surrounding area too, and kind of damaging some of the necessary nutrients or other things that are needed that probably help supply and promote growth of the tumor. And so one of the issues with desmoids is that we don't have an effective mouse model yet, because desmoids are difficult to grow in a murine model or any kind of animal model, honestly. So that's under development. But one of the reasons for that probably is that just taking the tumor and putting it in something isn't enough, right? So it does signify, because in cell cultures and when they've grown them in those environments, there have been other types of, things that they've had to put in. We know that there's kind of an inflammatory component or milieu within and around the tumor that are likely also contributing. So I think those local therapies probably impact that surrounding environment in addition to the tumor itself.
Thanks, that's super helpful. All right, and that's a good transition into the systemic therapies. So can you tell us what has been used, and are we still using chemo, or what are we doing nowadays?
Yeah, so I mean, I think a little bit of everything has been tried. So way back when, people were using kind of rhabdomyosarcomas, soft tissue sarcoma type therapies, like so standard VAC, vincristine, actinomycin, and cyclophosphamide were used for quite some time. And then people started to look at more kind of gentle or chemo light type regimens, knowing this type of disease and the nature of it, and maybe the ability to give more metronomic type therapy, so lower doses on a more regular schedule with less toxicities. And so the idea of blasty methotrexate was born out, and there were some small studies looking at those two agents. And ultimately, the very first prospective study in children with desmoid tumors was run by Steve Skapik through the Children's Oncology Group years ago. And although it wasn't a home run in the sense of like these dramatic shrinkage, there was a decent amount of stable disease. And the therapies, compared to the more cytotoxic, stronger chemotherapy regimens that we use for other things, definitely better tolerated, but not benign and not without adverse effects. And the other thing is, even though it was metronomic, it was IV. And I think the idea of needing a central access, device coming weekly and then every other week over the course of an entire year, which is what that therapy entails, is not necessarily easy. But as I said, overall, generally well tolerated, and you don't have as many of the long-term side effects of the medicines that you have with other chemotherapy types. So that was really kind of the start of, and I think in some circles, many pediatric oncologists still think of vinblastine methotrexate as kind of the standard of care, which is a very appropriate thing to do. Nothing has been shown necessarily to be better in children. There was a follow-up study to that where they actually looked a little bit more at desmoid tumors in terms of the biological components. And since we know that there seems that certain hormones are associated with desmoid tumors, and they tend to grow in environments where there's maybe increase in estrogen, and that's why there's a peak in fertile women, who are at a time in their life where their estrogen levels are higher. So a really good idea was that, hey, if we use an anti-estrogen type of agent, like tamoxifen, that may help. And then there's also the thought of NSAIDs, just as I mentioned, because of the inflammatory component and the ability potentially for some COX-2 inhibition. And so they combined an NSAID, Solandac, with tamoxifen, and did the second prospective study through Children's Oncology Group. It was generally well tolerated, but the results were not as promising. And there were a fair number of women young girls who actually got ovarian cysts from that treatment, though they weren't necessarily, they were found, I think, serendipitously, they were asymptomatic, but still significant. And so I think most people probably don't think about those therapies as kind of standard treatments in that sense, but those have are kind of the two, at least, main regimens that have been tested. There are some people who use vinorelbine instead of vinblastine, and that might be a little bit better tolerated. There's some people looking at giving some of these in oral form, but those haven't really been evaluated well in children to know if that's a better way to go. So from a systemic standpoint, those have historically been kind of where we've been. And I will say that over the last 5 to 10 years, there have been more somewhat targeted agents that have come about. I think tyrosine kinase inhibitor is probably the most well-known, mostly imatinib, but these studies that have been done have really only been done in adults. They're being used in children, but the studies or any type of prospective study in children is really limited to kind of single institutional or maybe multi-institutional data, but not done in a clinical trial format. So imatinib was the first one that was used that has shown some benefit. And then more recently, sorafenib had a phase 3 trial that showed significant benefit. And then pazopanib, both of these were randomized in adults. And then a pazopanib trial that also showed benefit. So there are certainly a number of people in the adult world who would think about using those frontline. In children, there are some people who would think about it, but we don't really have great data. And you're once again talking about children, and I think no one really knows what the long-term toxicities are of using agents like tyrosine kinase inhibitors that can affect bone growth and growth, plates and other things. And how long do you treat these patients, right? Like, we don't know, is a year enough, 2 years, 3 years? We do know that if you start and stop, you generally can get similar benefit, but and they're not benign. I mean, some of these or what's nice is they're oral, but they have a lot of toxicity, and there's a lot of patients who can't tolerate them, who have to dose reduce. I think one of the nice things is that even if you dose reduce, you tend to still get good benefit from these medicines with desmoid tumors, so you can get away maybe with a little bit less. So at least that, those are a couple, the tyrosine kinase inhibitors are probably, certainly the data in adults is very good. And if you extrapolate a little bit, it's probably okay, certainly in children. We don't know safety wise if that's the right thing to do. And I will just mention one of the other really interesting things. The nice thing about doing a randomized study is that in the sorafenib study, they had a control arm where they got placebo. And it was really an amazing study, because if you look at the placebo arm of that study, there were a number of patients who had regressive disease. Some of them met the PR threshold and some didn't. But if you look at that publication, there were a number of patients who got nothing, who had regression of their disease. And so it does once again point to the fact that upfront active surveillance, watchful waiting is a reasonable approach in a number of patients who have desmoid tumor.
Yeah, and just for our listeners, a PR is a partial response. So and that's based on some criteria that we use in the percentage that the tumor shrinks. So for a tumor to shrink that much without getting any treatment, it is really significant. Like Aaron started out the conversation saying, talking about just waiting is also a good approach. Wendy, I'll let you go if you have another question. If not, I can. Oh yeah, no, just
I know. Surprised
yeah. Well, I was just thinking about also, just to make the point to what you said, that with these tyrosine kinase inhibitors, you also have to look at how much benefit did the adults get, when you're considering that, because some benefit, if it's just as much as watchful waiting, then again, we talked about, we know not all these tumors will regress. But if some of them do, is it worth the side effect? And then, are they doing any of the TKI, tyrosine kinase inhibitors trials in children? Or I didn't know if you could speak a little bit about what trials they are doing currently in kids for desmoid.
Yeah, I mean, currently there are no we've tried to get a study like that off the ground, but we have not been successful to date. There's not a lot of interest in doing a desmoid study in children with tyrosine kinase inhibitors. I think there should be. I mean, obviously I have a personal bias, but many people feel like the adult data was strong enough that there's no reason to run, it's not like we haven't used tyrosine kinase inhibitors in children. So I do understand that piece of it, but I don't think, they're different diseases. We don't really have a good sense. Is it really better than, the vinblastine methotrexate? What are the toxicities, and long term, what does it mean? And so I do think it's a void, and it does make it challenging to make recommendations without having that data. In an ideal world, you would do a prospective study in children to be able to answer that more definitively.
I think that's so frustrating because, now that I'm at an institution where I go to an adult sarcoma board, and then I have my own pediatric sarcoma board, even though biologically they may have the same, 45 codon mutation and other things, my desmoids tend to happen in locations that are very tricky. I have a lot more head and neck desmoids than the adults who have these, abdominal wall or maybe intra-abdominal minor, pressing on nerves and in the faces of children. And it would be nice to know, because I don't have necessarily the luxury of active surveillance in that situation. It would be nice to know what I'm exposing them to in a prospective fashion. And so even though the biology appears, for what we know right now, very similar, I feel like my distribution is different than the adult group. So I would like to know.
Yeah, I completely agree. I mean, I wish you were with me when I was trying to make my case, but and in addition to just running a study, there was a recent consensus paper that we put out about tyrosine kinase inhibitors in children with desmoid tumors, and we did it in collaboration with our European colleagues. And in that paper, we proposed an international desmoid tumor study, which actually I think would be the best way because you're then increasing the numbers, and it would just be a wonderful way to kind of answer some of these questions. But unfortunately, there just wasn't enough support to kind of get that off the ground. I'm hopeful that maybe with some of the newer agents that are coming down the pipeline, that there may be some more interest just based on even better targeted agents. So we talked about tyrosine kinase inhibitors, but there's currently a clinical trial looking at something called a gamma secretase inhibitor, which affects part of the pathway of like the biological pathway of desmoid tumor. So it's even though tyrosine kinase inhibitors technically probably affect the pathway of desmoids as well, we don't really, it's not as clear exactly how. With a gamma secretase inhibitor, you can see how some of the pathway, which involves beta-catenin, which is an important protein within desmoid tumor growth and so forth, how those medicines can actually affect that specific pathway. So it's a little bit more targeted, it appears. There's been adult studies, and we currently have one happening in children to determine whether it's feasible and safe to give in children. And then if we get that data and then we get the publication that in the adult study that recently closed, it's beneficial, people would probably feel comfortable, using that medication in that population. There's also a beta-catenin inhibitor study that actually has been open in adults and is now open through the Children's Oncology Group in children that is fairly new and also very exciting. That seems to be a well-tolerated drug. So there are some very exciting things happening, and it's kind of nice that we actually have a few things to choose from when before we had very little. I just think it's going to be tricky kind of trying to figure out what is the order, right? What is the prioritized order of how you use these things? And at least for now, my prioritization is based on like all the things we've been talking about, like quality of life, side effects, chronicity, where's the tumor, how aggressive do we need to be? All those are different factors that we take in when we discuss these at our tumor boards, as well as like who is most appropriate for what type of therapy.
I know we're getting to the end of the hour here. Lisa was about ready to say the same thing, but because we've talked about it a little bit, about some of the challenges that we've had from a clinical perspective and research perspective, if somebody is listening and is angered or moved by this conversation about the struggles that we're having on the physician side and treating with our patients, what would you recommend for them to do to try to get involved with some advocacy, and who should they talk to if it's important to them?
Yeah, great question. I think with a lot of these rare diseases, it really is important that people advocate for themselves and for others. And one of the wonderful things that I think we've all experienced in the world of pediatric oncology is that we are small in number, but very loud in voice. And it's not really just the honestly, the oncologists are a small piece of it. It's really the patients, the families. They're the ones who actually make the biggest difference. They're the ones who form, foundations. They're the ones who help raise funds so that we can perform research. I mean, like part of our study that we're doing now is funded through the Desmoid Tumor Research Foundation, which is raised money so that we can actually do some of the research on our clinical trials to learn more about this disease. So I think one of the best things, I think it's hard to go at it alone. Someone has to start it, but you have, at least for desmoids, you have the Desmoid Tumor Research Foundation, which is actually now international. So there are locations in multiple parts of the world. They're a great organization. If you're not familiar with them, it's dtrf.org. And you can go on there and they would, there's resources, for education. There's ways to get involved, whether financially or just, like for the initiatives that I mentioned about, the coding and all those things, that takes advocacy from foundations and people to make the politicians really listen. And so that's really the best way to get involved, I think, is at least a good place to start. And from a desmoid specific, I'm not aware of any other foundation that is as significant right now in the field of desmoid than the DTRF Foundation. And there's a number of initiatives that I'm involved with and others are involved with through that foundation, clinically and biologically and research wise, that I think are doing a lot of good things in the field.
Thanks, Erin. Yeah, so great, so helpful. And it was so awesome talking with you today. We could probably talk for another hour. So maybe we'll have you back. There's so many things we could also talk about, but this has been so helpful, especially thanks, Wendy, for asking that question, because I think that is really meaningful to people because they want to be able to help and get involved and advocate. So awesome.
Yeah, I think absolutely. And I thank you for bringing awareness, for something like this. It's not a sexy topic. It's not a topic that is on the top of everyone's head until they've been afflicted by it or unless they take care of patients with it. But it's like anything in life, you never know. And I think it's just good to know about it and then where to go, what resources are available to help, to help people get through it and to help manage it. You want to, it's knowledge is a very powerful thing. So you want to we try to empower our patients and families who often actually know more about this than the providers who see them. And I think that says a lot. Yeah.
All right. Thanks so much. And we will talk to you all soon. Any other last words, Wendy?
Nope. That's all I had.
All right. Thanks, Dr. Weiss. It was great. All right.